So let's start with the our things, right? So welcome to all on Medical MCQ for all. This is myself, Dr. Munjal Pandya. I'm a hemato-oncologist and bone marrow transplant fellow. So I'm going to guide you today for the excellent MCQs today, and we'll discuss a lot of questions today. So I did my fellowship in hematology and oncology, and I'm practicing for almost 20 years now, and coaching experience of more than 10 years. We have a nice team, including Dr. Aarti, who is a consultant pediatrician, taking many lectures of this pediatric in a day-to-day coaching. Dr. Maddy is an internal medicine and cardiologist, so she is also excellent speaker. Dr. Shikha now recent is in Dubai now. She is attached with the Esther Clinic as a consultant gynecologist in Dubai recently, but she is taking live online lectures from medical MCQ, and also one of the Dr. Deepal is also joined recently. So we are updating the profile as well. So we have now two gynecologists on panel. So if anybody has any queries, you can feel free to ask them. Dr. Ankit is also a gastroenterologist and consultant in my city. So this is team, and this is Pallavi and lot more teams new. Anjali, as you know, she is also in our team based at Dubai. So she is taking care of data flow from UAE. Our contact details. This is recently updated book for PROMETRIC 1000 MCQ with answers and explanation. Absolutely, there are a lot of doctors calling me. Explanations are there or not? So it's absolutely there. Without that, it is of no use. So if somebody is fond of book, they can order it. And this is lots of promotional offers. So talk with the Pallavi just to save the time. Data flow is done from Dubai, as I told you, Anjali. This is the contact details of Anjali, right? So if anybody has any queries related with the documentation, data flow, license change, license transfer, right? Or anywhere they stuck up for exam booking, any logistic with the exam and data flow, she is the best person. Both the numbers are there, UAE and Indian numbers, so you can contact them. Again, we launch a excellent mock test module, right? And that module will help us to do the self assessment. So I request and urge those who are already in our subscription. I'm seeing lots of doctors are not doing the mock test. So I strongly recommend you to do the mock test, because without mock test you cannot assess yourself how much the score you are doing in every mock test. And this is the best way by which you can know your progress, that okay, fine, first mock test 50, second 55, 60. So whether it is improving or not. And I generally tell you, if your score persists only 70, 75% in each three consecutive mock tests, then it is good time to go for exam. Randomly going and giving the exam, it waste of time, money and energy. So just prepare well. That's what I want to say. And another good news is that we are launching the EMRE, EMRW, that is Emirate Medical Residency Entrance Exam. So probably after a couple of weeks, I'm also visiting to Dubai, Abu Dhabi, and Sharjah as well. So those who are there, they can meet us and my team there in this UAE. So very interesting. This Emory program we are launching. Website is launched already, but probably it will be live in a 1 or 2 week. And we are starting the first coaching from tomorrow onwards for specialized Emory. Those post MBBS, those who are interested in doing post graduation in Dubai or UAE, again, you can contact Dr. Anjali. She is also in our team of this Amri. So she will completely guide you for all the process and everything. So let's start our main things, our mock test today. So without wasting the time, so get ready. I wish each and everybody will give the answers properly, read the questions properly, and I'll give you the tips and tricks how to crack the MCQ. So first questions in front of your screen. A 57-year-old man present with an annual physical examination. He is generally in a good health but complain of recent difficulty in urination. He reports that he has a weak interrupted stream with the dribbling. He denies nocturia, urgency, bladder fullness, daytime frequency, hematuria, fevers, chills, or family history of prostate cancer. On examination, he is afebrile and has no costovertebral angle tenderness. His abdomen is soft and non-tender. Which of the following would be the first appropriate screening test for this gentleman? Cystoscopy, digital rectal examination, PSA prostate specific antigen, Now you suspect it's a malignancy, you go for biopsy directly. You go for urine culture and microscopy. So urine routine microscopy and culture, right? And one more questions from my side. What is the guideline for prostate cancer screening and what are the tests available in the market? So your time starts now.
Prostate
It's
antigen.
written.
See, sir.
Yeah, so you post in the chat box, doctor, if possible. So we will discuss this. So I will definitely discuss. Who has told the answer C? Now you can unmute your mic. When you want to interact, you can unmute your mic so we can discuss. We can completely properly discuss everything now. Yes, yes, Dr. Ria. Now you can unmute your mic and we can discuss little bit. So I will completely guide you for these questions. So you won't miss this prostate part now. Yes, Ria. Don't shy. Don't worry. It's a learning platform. So we'll discuss. Yes, Dr. Ria. Don't want to speak? Fair enough.
I think it's
Yes, anyone?
option C, sir.
Yes,
Age.
Dr. Ria. One by one. Yes, Dr. Ria. Tell me.
Yes, I think it's option C.
Option C. So let's discuss option C, right? So now tell me your answer is a PSA. So first of all, first trick to my all students, you keep in mind three. This is I given every time to all the students, especially the new ones they doesn't know. For solving any MCQ, you need to have three things, Dr. Ria. First thing is a diagnosis, second thing is an investigation, and third thing is a treatment. So until and unless anyone know these three things, it is fairly high chance that you can end up with the wrong answer in your exam, right? So tell me what is the diagnosis, Dr. Ria, here, how you investigate and how you treat this patient. So let's get back to the questions for you, right? So what do you think? What
Diagnosis
could be
is
the diagnosis
BPH.
is here? Okay.
BPH.
So whatever you tell me, I will write down. BPH. If anybody has any other difference of opinion, they can discuss, because discussing the things we will solve in these questions, we have at least we'll solve 10 questions. Though we have one MCQ, but I will solve 10 MCQ in same question. That is why I'm discussing. Otherwise, I can read and I can go ahead and half an hour mock is over. So it will not at all help you. So one is BPH. Anybody has any other idea? Yes, Dr. Irfana, you told BPH. Hello.
57 years old.
So who told the BPH? So BPH is one options. Any other differential diagnosis? Only BPH. That is the only
The prostate
diagnosis.
cancer.
If I can say I'm thinking of prostate
Cancer.
cancer, not a benign. If I can tell you
Yeah.
this is my sense is likely because he's a 57-year male, right? Blah blah. He's elderly male, right? So it's not all the time mandatory that they should have family history of prostate CA. So my diagnosis would be CA prostate or possible CA, possible BPH, possible CA prostate. So now tell me, Dr. Ria, how you differentiate this BPH and prostate CA first of all?
Sir, history duration. This is the acute history.
Sorry, Dr. Hina.
Sir, he is generally in good health, right? He don't have any other complaints other than recently difficult with urination.
Okay, so the BPH is usually is generally in a good health, right? And
Yes, sir.
prostate cancer probably they may have some symptoms or they may have
Yes.
some associated symptoms or
Symptoms,
constitutional
back pain,
symptoms
anything.
or anything back pain probably because of bone metastasis, but primarily he also has some kind of urinary complaint, right? Because the
Yes, sir.
prostate you must be knowing, right? So this is a prostate. Let's just go back to little anatomy as well, right? So this is a kidney both the side, right? So they drain into the urinary bladder, right? This is urinary bladder, right? And just below the urinary bladder this is a gland called as a prostate. This is the prostate, right? And from the center of the prostate the urethra is passing. So whenever prostate gets enlarged, right, whenever the prostate gets enlarged, it compresses in the urethra. So what happens? The bladder is distended because fluid is filled, right? He cannot empty well, right? So urgency, frequency, dribbling, right? Post void urination, these all symptoms develop because of this only, right? So
Yes, sir.
this is the one thing, right? So in this case, what do you think? This is benign case or this is malignant case, right? So
Benign.
likely benign, right? So
Yes.
what point favoring in the benign? That also we need to know. What point favoring into the benign, right? So 57 years, you can have BPH, you can have prostate cancer as well, right? So he's in a good health. They are saying generally in
Yes,
a
sir.
good health, but
Yes, sir.
recently difficult in urination. What do you mean by recently difficult in urination? So if any patient 57 years of age, otherwise healthy, recent difficulty in urination, what you diagnose for this patient? Probably you diagnose BPH. Okay, fine, fair enough, right? So what do you want to do from this A, B, C, D, E in BPH? Or is there any clue? Why not it is UTI? Why you don't want to do the urinary culture, Irfana? Why you don't want to go for urinary culture?
In
We want to
UTI, fever
exclude
will
There is
everything.
be.
no, yeah,
Yes, go ahead. So if there is a UTI, the
there is
UTI,
no painful
then
maturation, hematuria or anything, sir.
exactly. So no
Fever,
fever, fever is not there.
no hematuria, no painful
Hematuria is not
maturation.
there. No painful micturition. No leukocyte. No WBC in the urine. No lower abdominal tenderness. Right? Nothing.
Yes,
So
yes,
abdomen is soft. They are saying soft. Also non-tender. Right? So absolutely fine. So urine culture and routine does not help. If there is a history of fever,
sir.
leukocytosis, burning, frequency, lower abdominal pain, vomiting, fever, isn't it? This is all the
Yes, sir.
UTI. So nothing is there. So your job in exam is not just to, I mean, in practice, in exam, you won't have this much of time to discuss in the question. Hardly you have a
Yes,
1 minute, 1.5 minute for one question, right? Otherwise, you will end up. I got a lot of calls, sir. I have mismanagement in the exam and I got failed. Why? Because end up with 100 questions, 50 is left. Why? Because 3 hours, 3.5 is gone. So you need to do practice from day one. And this is the absolute high yield tips I'm giving you. So while you are practicing doing the mock test, your job not just to tick the correct answer or whatever the answer, but your job is to rule out the other causes as well. Then you have a real learning. So here you are not mugging up the answer, right? Mugging up the answer 1 minute, one MCQ, right? It's done, right? So urine culture, why not? Why? Because this is all absent. Why not prostate biopsy? Tell me, why not prostate biopsy? Why not
Pro
prostate biopsy?
prostate biopsy will be done if the palpable mass is present and increased PSA.
Okay, so
But
increased
we
PSA
are
and palpable mass. These are the two things. So
yes,
have
sir.
you palpated this mass in this patient? Is there
No.
anything they mention that what is the digital rectal examination or something they
yes,
have
sir. We have
mentioned
to
here?
do prostate examination through digital rectal examination only.
So answer is then chain to B. Few are saying C. Now this is by your sense it is B. Am I right? Yes or no?
Yes, sir.
Yes, sir.
Right. So now again I give the
But
liberty to everyone.
sir,
If you want to change the answer, change the answer. B or C. So prostate malignancy when you are suspecting intense of along with just symptoms because BPH means benign prostatic hyperplasia and CA, there is no other way to differentiate between this except the digital rectal examination, sometime PSA, right? Transurethral ultrasound, transrectal, sorry, transrectal trust. This is
Transrectal.
called trust, transrectal ultrasound. And if you suspected or mass or high PSA, you go for the biopsy. I will give you that chart because there are hundreds of questions comes from the prostate. So this is very absolutely high yield. So at point we are not suspecting prostate cancer frontly, right? Because there is no absolute evidence. Without PR and without PSA, we cannot do. Nobody can do the prostate biopsy for sure, 100% without PSA and without transrectal ultrasound, trust, right, or digital rectal examination. I'm practicing this for last almost more than 20 years as a medical oncologist. I'll give you the simpler idea, right? How you can make the job easy, right? So we have not only onco questions, we have a lot of other varieties as well. But this is the first question. So neither we know the PSA, neither we know the transrectal ultrasound, neither we did DRI. So how can you suspect? So we are not suspecting as of now. So prostate biopsy is gone. Now we have three options. Anybody wants to put any comment, I would be glad and happy. Now, see, out of these three, do you think cystoscopy is the answer for this? Yes or no? Anybody?
No, sir.
Anybody favoring cystoscopy? No.
No.
So
No.
cystoscopy is gone. Cystoscopy, when it is indicated, when you have obstructive uropathy, when you have a unexplained hematuria, unexplained, most important one is a unexplained. You have renal stone and hematuria, it is not unexplained. You know the diagnosis, right? Why? Because there is a stone, there is hematuria. This is called explained hematuria. I'm talking about unexplained hematuria. So you did ultrasound, you did MRI, you did lot of things, you did trust, everything you did, but you don't get any answer. What is the cause of hematuria? Means blood in urine. Then last investigation is cystoscopy, right? Cyst is a urinary bladder is a kind of cyst. So cystoscopy, entering a scope through the urethra into the prostate and then going up to the bladder is called cystoscopy. It is can be done in a local anesthesia as an outpatient procedure, right? So when we diagnose a CA bladder, we are doing in every patient cystoscopy, do the biopsy, dig transitional cell carcinoma, then we do staging and then we treat. So three options out of this five is gone. Now this is very close to options. Anybody wants to do any comment, I would be glad to discuss. What is the first? PSA is first or digital rectal examination is first? Because what they are asking in the last line and another
So I
First
extremely
think
appropriate
the
screening
digital
test.
rectal examination would be the answer, because in the question they're asking what is the appropriate screening test, not a diagnostic test.
Yeah, first
excellent.
appropriate screening test.
Wonderful, Kanika. Wonderful. So see, this all word are extremely important because this is like a word game. MCQ solving DHR, the MOH is a and one tip from my side. Whenever this is still a small scenario, believe me, this is small scenario in your exam. Sometimes in your exam there is a 10-line scenario. Don't I'm not trying to scare you. I'm trying to make you understand. So here, what happens in this? Whenever you don't understand anything, na, read the last line properly because in last two lines there is a crux of the question. So if somehow what happens when you going from up to down, you forget first five lines. What happens in first line? So just remember which of the following would be the first appropriate screening test, right? So they are asking screening is different from diagnosing, right? So screening is different, diagnosis is different. So screening could be simple radiology, diagnosis could be biopsy, right? Am I right? Yes or no, Kanika? Right? So screening test,
Yes,
right?
sir.
So screening test here. So anybody wants PSA, anybody's answer is PSA, please open up the mic and discuss with me. If somebody is saying the PSA is the answer, discuss. Learning platform. You never learn these things in book. Yes, tell me
Hello, sir.
anybody.
Good morning.
Yes, sir. Very good morning.
Sir, Utpal here.
Go ahead.
Good morning.
Quickly go ahead. If your answer is PSA,
Sir,
explain me
yes, sir.
why
My
PSA.
answer is PSA.
Yes, so
Sir,
now tell me why you want to do.
by PSA we can differentiate whether it is the cancer or whether it is benign.
Wonderful. So this is absolutely a wrong answer. I will give you the authentic information on that. I am dealing with this for almost more than 20 years. So PSA is a prostate specific antigen. Somebody is disturbing me on the background. Let me mute all. Those who wants to interact, just interact with me directly. Fine. So I muted all. You can unmute and you can discuss. Utpal, doctor. So this is what the thing is, right? So what is this, right? PSA is prostate specific antigen. It's a release from the prostate gland. Release from the prostate gland. That is how it the name comes. Prostate specific antigen. There are two things. There are 25% of the patient in our OPD and our statistic of last many years. 25% of the patient who present in a stage 4 prostate cancer. Stage 4 means advanced or last stage. There are four stage 1, 2, 3, and 4. So I'm talking about stage 4. So 25% of the patient with stage 4 they present with the PSA normal. PSA normal. Normal PSA is 0 to max 4 macrogram per liter. This is a range. So up to 4 is normal. So there are 25% of the patient with advanced stage 4 PSA is normal. So PSA does not give you idea about the prostate cancer, number one. Number two, 25 to 30% of the patient, right? They present with high PSA and no cancer. High PSA, no cancer. Example, benign prostatic hyperplasia. prostatitis, prostatitis, injury to the prostate after digital rectal examination, right? These are the things where you get high PSA, but there is no cancer. And here the PSA is normal, but there is a cancer, and that is also advanced 4. This is absolutely word to word from the book. So you open up any book and read this PSA, do more research on PSA. I did 1,000 times for last 20 years. So this is a conclusion I'm telling. So now, Dr. Utpal, do you think that normal PSA will exclude the malignancy, or high PSA would be important? And high PSA, you start the treatment of prostate cancer. Yes,
No,
Dr.
sir.
Utpal.
No,
Now
sir.
comment. You got it.
No, sir.
You got it. This is the
Yeah, I
literature. You
got.
got
I
it,
got it.
right?
I got it.
So only PSA is at all not any carrying any importance. Any PSA does not carry any importance without digital rectal examination. So digital rectal examination is the number one things in any suspected prostate patients, whether it is a benign or malignant. So you cannot bypass the digital rectal examination. So here answer is digital rectal examination. Let me go little forward. If the digital rectal examination say there is a irregularity in the surface, right, of prostate, right? It is basically palpated from the rectal side. That is why we do in any suspected patients of urinary complaint, benign prostatic hyperplasia or malignancy, we do digital rectal examination. We try to check the mucosa, how the mucosa, smooth mucosa, nodularity, tenderness, some mass is seen. In that case, second most important thing, first you do the PSA. After doing the PSA, you do, right, whatever the PSA
Biopsy.
Prostate
comes,
biopsy.
whatever PSA
Prostate
comes,
biopsy.
even if you are suspecting clinically on digital rectal examination that mucosa is not smooth, patient is symptomatic, patient has a, I mean, classical case of benign or malignant chances, then in that case you must go for the digital rectal examination. And after digital examination, you do the prostate, this rectal ultrasound, and you do the random biopsy as well, right? This is how the things. If it is benign, you treat accordingly. If it is malignant, you treat accordingly. That's it. So this is the what the protocol is, right?
Sir,
So in
can I
this
add on?
case, 1 minute, 1 minute, 1 minute. Let me finish. You can ask. So this is how you have to treat, or you have to invent or investigate the patient, right? So it is always, and nowadays what I feel in my OPD for many years, that no doctor is interested in doing the digital rectal examination. Why? Because we are always dependent on the hi-fi investigation. Oh, you do transrectal ultrasound, you do PET scan, you do MRI, you do CT scan, you do blah blah, right? Hi-fi PSAU, but never touched. Nobody just bothered 2 minutes, and it is the most important investigation, digital rectal examination. Find out the any book in this world, if they are not mentioning digital rectal examination, post this in the group, that see, sir, this book doesn't mention anything about digital rectal examination. It is 100% there in any book of the world. So digital rectal examination you cannot bypass in any benign or malignant prostate suspected cancer. So clinical suspicious, do the digital rectal examination, right? If you suspected, you do the PSA, then ultrasound, and then accordingly the biopsy. And on depends on biopsy, benign versus malignant, you go ahead and treat the patient. Now somebody is asking me the questions. Yes, now it's open. Tell me.
No, sir, just for add on.
Yes, please add on.
Increase of PSA, just do a, if it is a we do DRA and we do PSA and we see the PSA is being increased and irregular mass, do a biopsy. If you can't find a mass in the rectal examination, still you are suspecting prostate cancer, and
Yes,
do a transrectal
yes,
ultrasound. So if you find in transrectal ultrasound mass, then do a biopsy. If no mass, still do a multiple blind biopsies.
exactly. So mass is clear cutly seen, you can target the mass. But if there is a significant clean, and any PSA more than 10 is significant, for your knowledge. This is how we go clinically and our international guidelines of treating PSA or prostate cancer. So anything more than 10 PSA is a significant, right? Rise in the PSA, right? So you should not ignore it. You suspect it. So if you do trans ultrasound, rectal ultrasound, if you find clear cut mass, your job is done. You directly take the biopsy from that mass, right? And if you don't get any mass, then you do the multiple random biopsy from the suspected area, right? Because this is possible in a very early stage, probably 1 or 2. But if there is obvious clear-cut mass, significant complaint of the patient, you definitely get the mass in rectal ultrasound. So you directly hit the biopsy. And commonest histology. Can anybody knows what could be the commonest histology once you do the biopsy from the prostate? What could be the commonest histology? No options. Anyone? What could be the commonest histology? Say head and neck squamous cell carcinoma.
Adenocarcinoma.
Excellent.
Adenocarcinoma of prostate.
Adenocarcinoma. Adenocarcinoma of prostate. It is one of the most common, right? So there are a lot of things can happen histologically. You can see neuroendocrine tumor of prostate. You can do some kind of metastasis. You also see, but commonest pathology or histology, right, is a prostate cancer, is a adenocarcinoma, right? So your homework is, anyone know what is the Gleason score? Gleason score, Gleason score. Anyone knows Gleason score? Yes or no? If somebody knows, unmute your mic and discuss. If you don't know, go and read the Gleason score. It is also a exam. It is mainly a job of pathologist. Pathologist knows better. So once you do the prostatic biopsy, and you see under the microscope, right, and you see what is the histological changes, there are 5 and 5 score. So out of this 5 and 5, what's in? So you can give a Gleason score. So Gleason score of 3, 0 to 3, 4 to 7, and 8, 9, 10. Mild, moderate, and high grade, right? So depends on that. You can treat patients accordingly as per the risk stratification. So those who do not know at all about Gleason score, remember, write down in your notes, come in the class with the note and pen every time. So you get some homework, so you can read it. It's all our high yield question. So go and read it, Gleason score. If you don't understand, directly message me on my WhatsApp. I will discuss you one-to-one as well. So here the correct answer is the literature is an annual digital rectal examination after reaching 50 years of age is most universally recommended screening tool for prostate cancer or suspected prostate cancer, and it is mandatory part of the physical examination for a middle-aged man with a recent onset of complaint. So now everything is matching in this case, right? Nothing is very mysterious in this case, right? Man of 50, more than 50, here 57. So suspected case of malignancy, anytime, any symptoms which develop suddenly, all of the sudden, right? Recent is something suspicious. Recent cough in a smoker, suspected lung cancer. Recent onset of bad diarrhea after 55 years of age, CA colon. Recent development of change in the voice in a chronic smoker, CA larynx. This is just clue, right? So recent is very dangerous one, right? So all of the sudden everything went smooth, but what happens all of the sudden? So he may develop something bad, right? So you just have high suspicious in your mind while doing the questions and answers. Any questions with this? Anything, any confusion in this? Anyone wants to make any comment or add on, put on? Anything, Parvati? Kanika, anything you want to have any queries?
No, sir, everything is clear.
Wonderful. So though this is very absolutely high yield, sometime I'll take completely screening of all cancers. Those who do not know, recently somebody I was discussing day before yesterday with one of my students, there were screening 5 or 10 screening questions in DHA. Cervical cancer, cervical means cervix, right? Cervix cancer, breast cancer, prostate cancer, and colon cancer. As it is, what we discuss here, as it is comes in exam. So those who are not have clear cut idea about screening program of each things, go and read it. This is another homework we will discuss in some oncology, dedicated oncology class. This is mock test, so it's a mixture of many questions, but I will discuss shortly in my this next couple of lectures. Cervical cancer, meanwhile you read it. High yield point, mammogram screening, prostate screening, and colon cancer screening. This all 4 cancer, 100% 2 or 3 questions come from this. So if you don't want to lose any marks, go and read it. Any confusion, post me. That's it. So I'll go ahead, Dr. Kanika, for next question. Is that okay?
Yes, sir.
Wonderful. Excellent. Thanks for your participation. Question number 2. All are high yield, all interesting. There are lots of learning in one question. So probably I discuss 5-10 questions in prostate CA, right? Lots of clarity. Second question. 24 years old childcare worker is 29 weeks pregnant. So patient is a 24 years. The job is childcare worker, and 24 years of girl having 29 weeks of pregnancy is currently working. One of his children is working in a child care, and one of the children where she is working, he has diagnosed children with a rubella last week. So pregnant woman, 24 years, she has a 29 weeks of pregnancy. She is treating and managing the child in child care. One of the child has a rubella. Now she get into the contact. So one of the child she cares was diagnosed with rubella last week, 1 week before. Rubella antigen testing done, and her IgG titer is done. So IgG titer is negative. For whom? Patient. The lady who is a pregnant, her IgG titer is negative. Rubella antigen testing is performed and her IgG titer is negative. What is the next most appropriate step in the management of this patient? So first you need to understand the question. So I think I given you clear cut idea. Anti-rubella antibody you now going to give this 24 years of lady because she exposed to rubella and that is dangerous for the baby. Betamethasone you want to give to this patient. Rubella vaccine you want to give now to the patient. You want to give rubella vaccine after delivery to the patient, or you want to do some kind of ultrasound for the fetus, right, to just get some congenital malformation of the baby.
And
So you
just
think
one,
over it. You post your answer, doctor, in the chat box. We'll discuss. I know who has given the answer. So I will discuss with each and everybody. I will not in hurry, right? Our class will last for 1.5 hour minimum. Yes, anyone wants to don't want to speak, they can put the answer in chat box as well. We have a chat box. Yes, Manjit Singh, what's your answer? Manjit Singh.
Sir, I think so. Ultrasound of fetus for seeing the congenital anomaly or any defect.
Okay, fine. So let me
Because
ask you a couple of
rubella
questions.
we can't give in pregnancy. It's a contraindicated
Okay, so
vaccine.
in pregnancy it's contraindicated, right?
Yeah,
So say for example, your answer is a ultrasound, right? So I did
yeah,
ultrasound.
yeah.
I did ultrasound of the mother, and ultrasound is no abnormality or no anomaly. So is it solve the problem of the mother who is already been exposed to the rubella? This is about baby, ne? Uterus
Yeah,
ultrasound of the fetus. You see the fetus. Fetus is fine,
yes.
is playing well. At the 29 weeks of gestational is fine, right? Placenta is fine, baby is fine, cardiac activity is fine, limbs are fine, everything is fine. Does it solve the mother's problem who exposed to rubella? So is it the most appropriate step? They are what they are asking. What is the next best step in the management? So doing the ultrasound, do you think it is the best management now in this patient? What is the best among this A, B, C, D, E? What helps to the patients by doing what it helps to the mother or baby or both? Yes, Dr. Ria, any comment? If this questions comes in your exam, how you react? Think this question is not in mock test. Think this questions in front of your DHA exam. What will you take? Yes, we have more than 30, 40 doctors in the group now, and only answer
she's
is five.
give the rubella vaccine after delivery, sir.
Give the rubella vaccine after delivery. So if you give
Yes.
now, what happens?
It is an congenital malformation will be high for the baby.
So, okay. So what congenital malabsorption? What is the most common congenital malformation? If you give this baby
PDA, sir. PDA,
huh?
cataract, deafness.
CDA. So what is the full form of CDA?
Patent ductus arteriosus.
PDA, not CDA. PDA, patent
PD.
ductus arteriosus. So what
Yes, sir.
happens in patent ductus arteriosus?
It's an abnormal. The valve won't close. It is an duct. The main
Where?
blood vessel. Sir?
So yeah, you go ahead. You go ahead. You are going well. So I'm just trying to understand your concept of PDA. What do you mean by patent ductus arteriosus? Just tell me in a brief, whatever is in your mind and brain about the
Okay,
impression
sir.
of PDA. You tell me.
It is an abnormal vessel which connect the aorta and pulmonary artery. After delivery, actually it closes. When the rubella infection, it won't allow the PDA to close, and it will cause the murmurs and cyanotic heart disease.
Okay. So PDA closed at what time? Say baby delivered. Baby after 4 weeks, 6 weeks, 8 weeks, 12 weeks. At what physiological time this PDA should close automatically or by naturally, when it will close? And at what time you
Within
think
12
that
to
now this is a
24
problem?
hours.
Within 24 hours, it should be closed.
Yes.
So if
Yes,
doesn't
sir.
close in 24 hours, what do you tell? Then you tell this
Uh,
is PDA, isn't it? If it
yes,
doesn't
sir.
close, then you tell that okay, he's suffering, this baby is suffering from PDA, pattern
Yes,
ductus
sir.
arteriosus. So is there any medicine or operation or surgery or some drug which close this PDA if it is not closed, or
Indomethacin.
only surgery? Sorry,
Indomethacin will help to close the PDA.
indomethacin. Okay. So indomethacin will what happen? What it will do the indomethacin in this patient? How it close?
Not sure, sir.
Fair enough. If indomethacin doesn't work, what is the next step? These all are the question, doctor. Believe me, our job is not just to find out and mug up the answer that oh, you are going extremely well. I'm very happy the way you are answering me. You have very much nice concepts,
Rubella
right?
vaccine after delivery.
Yeah. So that is the answer, right? That is the answer. But I ask you the another question. If the PDA
Do a
doesn't close,
procedure to close the PDAs. Spontaneous closure is rare, sir, because in 80 to 90% it won't close spontaneously if it is a PDA already staying. Better to go with the procedure, sir.
fair enough. So
Stitches.
PDA, everyone, those who not have any idea in this class, so just remember three things about PDA: how you diagnose PDA, how you investigate PDA, and how you treat PDA. I had given this triad as my name's Munjal's triad. Don't take it otherwise, right? Until and unless in your clinic, even when you are working in your hospital, clinic, medical officer, ICU, until and unless you know the three things, you can't manage patients well. So whenever, whether it is a viral fever, simple viral fever, this triad applies. What's the diagnosis with cough and cold? How you investigate, how you treat. That's it, simple, right? It applies to viral infection, it applies to extremes of leukemia, lymphoma as well. This triad is everywhere. Any patient you see, think of this triad. That's it. So here the best answer is give rubella vaccine after delivery. Antiviral rubella antibody will not help this patient. Already she is infected, so she may develop natural antibody. Dexamethasone steroid for the premature delivery for maturation of lung not required now. Rubella vaccine is absolutely contraindicated in pregnancy. Ultrasound of fetus will not help the mother or baby as of now, right? And even you can't avoid the anomaly. Once anomaly is developed, it's developed. It won't help. But you want to prevent something, so you must give the rubella vaccine after birth to the mother. So that is the most appropriate answer. Is that clear to everyone?
Sir, if before the ultrasound anomaly is already occurred, then we can go for the termination of pregnancy also.
Yeah, but this is 29 weeks, sir. So almost in last month of last trimester. So it's a bit difficult, na? More than 5 months of pregnancy, it's very difficult to terminate the pregnancy, right? So that's the thing. So you should
Sir,
be very careful in selecting the answer. There is no post-exposure prophylaxis available for rubella, and immunization during pregnancy is contraindicated. It's a live vaccine, and pregnancy itself is an immunocompromised state like tuberculosis, HIV, diabetes, immunosuppression drug, leukemia, lymphomas, immune deficiency syndrome. Like that, pregnancy is also a immunocompromised state, right? So you cannot give any live vaccine in pregnancy, and this is your homework, right? This is on your homework. Make a list of vaccines contraindicated in pregnancy. Anyone wants to tell me five vaccine names, right? Five vaccines name which is contraindicated in pregnancy.
Uh, polio vaccine, all live vaccines are contraindicated, sir.
Yeah, so I want to know that five live vaccine name which is contraindicated.
Sir,
MMR,
MMR,
rubella.
Yes,
polio.
MMR. I write down here whatever
BCG,
you tell me. MMR,
BCG,
polio. BCG is a live vaccine. Anyone knows
no,
BCG is a live or killed? Anyone?
live
Anyone?
vaccines, right?
Live, sir,
Live
It's
live
a
vaccine.
live
vaccine.
attenuated.
Right. Live attenuated. Okay. What else? Three vaccines. This is
Polio.
BCG, polio,
Polio
MMR.
already.
I want
Varicella?
five names. Varicella,
And
Yes.
pneumococcal.
pneumococcal. So now your homework today, first homework. This is extremely high yield questions. So I cannot cover in 1.5 hour lots of things, but I give you the clue in every MCQ. What are the live vaccine and what are the killed vaccine, which is given in a pregnancy and which is contraindicated in pregnancy. This is homework. Those who do not know, you must go and read it. You go and must read it. These all questions will come in exam for sure, 100% guaranteed my side. All clear?
Sir, um, regarding indomethacin, sir, I'll complete that.
Hmm.
Indomethacin is a non-cyclo-selective cyclooxygenase inhibitor, which will produce the prostaglandin. So, which will stop the production of prostaglandin. Inhibition of prostaglandin will lead to the atrial vasoconstriction. So, the PDA will closes.
Sorry. Can you
Thapparam.
repeat, please? I got up to the last, but last sentence I missed it.
Yes,
So you
inhibition of
give the
prostaglandin.
yes.
Inhibition of prostaglandin production results in atrial vasoconstriction that will close the PDA, sir.
That's correct. So that is mechanism of action. That means
Yes, sir.
how it close. So this is mechanism of action of a
Yes, sir.
prostaglandin. How prostaglandin close? If they ask, it's little less expected questions, but at least you should know what drug close the PDA, right? So I would be glad if you know the mechanism. Extremely happy, but at least you don't know, you must know the drug, right? So very interesting. Thank you very much. So this is again a second questions. I don't know whether how much you make it right or wrong. So you check your score. You everybody check your score. First questions, what the answer and what you posted the answer. If you posted two wrong questions, then it is not a good score for you. Means you need to work more on yourself, right? Third question. So check your score. You don't need to display me what was your score end of the mock test, but you assess yourself. If it is less than 5 score, absolutely not a good score. So you are less than 50%. We need at least 70% in each mock test to go for the exam. Third questions in front of your screen. Again, this is uh, first is a prostate cancer. This is liquid malignancy related. 47-year-old woman present to the clinic concerned about her ill health. She has noticed over the last 3 months that she has been suffering from headache, fatigue, recurrent infection. She notes that she has rarely been to a doctor before. Otherwise, leads an healthy lifestyle. So she was very healthy, but now she is ill. She decided to see a doctor when she noticed patchy rashes on her arms. On examination, there is no organomegaly. Organomegaly means no hepatomegaly, no splenomegaly, and blood test revealed MCV of 105, pancytopenia with bone marrow appearing hypercellular on the biopsy. So, what is the most appropriate diagnosis for this patient? So, that is the question. So what this scenario, what this lady suffering from, right, fits into the which of the scenario? So what could be the diagnosis? Is it chronic myeloid leukemia? Is it myeloproliferative disorder? It is aplastic anemia? It is iron deficiency anemia? Or it is acute lymphoblastic leukemia? So now your time starts now. You post your answer in a chat box in next 10 seconds. We'll discuss. Dr. Aishba Neha, can you interact with me? Dr. Aishba, you can unmute your mic and you can interact. So there are still more than 30 doctors who did not posted their answer. 20 doctors did not posted the answer at all. Post. This is what comes in exam. Don't shy. Post. Post the answer. Everyone should post the answer. Dr. Afrin Shah, can you interact with me? Dr. Afrin Shah. Yes, Dr. RHP. Who is Dr. RHP?
Sir,
Yes, myself,
Dr.
Dr. Radhika.
Afin, sir.
Yes, Afrin. Sorry. Yes, tell me, doctor. So, what do you think?
I'm not,
What do you
I'm
think?
not
What could
sure.
be
I
the
said and chat box have given myeloproliferative because
okay?
of pancytopenia.
One minute.
No, no,
One
no.
minute. One
It's
minute.
hypocellular. Sorry, sir. It's
We will
hypocellular. Cells are
okay.
less.
MCQ we will discuss. So, first of all,
Okay,
what
okay.
is your diagnosis, or you can change your answer if you wish. Huh? I'm not forcing you to change. I'm trying to understand because in this case, you will become expert in five things. Not only the answer, I will make you at the end of 10 after end of the 10 minutes. Everybody in this class will become expert of these five things. Though you don't know nothing about this, but within next 10 minutes, you will expert of this five hematology. Yes, now tell me, Afrin, what could be the diagnosis? You want to read the question scenario, you read it. Because if those who are developing the skill of reading the questions well, 99% their answers are correct. Because in scenario, everything is given. But we don't bother ourselves to read it well. So we randomly give the answer. So if you read well, you understand well the complete
ये पढ़ने
scenario,
वाला है
clinical history, everything. If you read well, you can answer any questions. Probably you don't need to see the options as well because completely in your
Sir,
mind.
option C, aplastic anemia.
So now you change the answer from myelodysplastic to aplastic anemia. Are you sure? We go ahead, discuss the aplastic anemia.
Because it's pancytopenia and hypocellular on
Cytopenia.
pans.
Okay, fine. So now you tell me, Dr. Afrin, so aplastic anemia patient, how do they present? How do they present? Aplastic anemia.
Aplastic anemia, weakness, fatigue, and all over. Symptomatically, they will be having anemic presentation.
Okay, fine. So this is one presentation. That is the clinical presentation, right? What else the next thing? So now I tell you, I treated hundreds of aplastic so far. So first of all, age simple. These are the almost 20 to 50 years young females. Usually it's autoimmune, so more commonly in female. This is how. So 20 to 50 years of female present to you with the three complaint. In CBC, there are three things. No need to mug up. No need to mug up. Hemoglobin low, that is why they have fatigue because of oxygen carrying capacity of blood is reduced. WBC low, right? Infections because WBC is a firefighter or fighter or immune cells, right? Neutrophil lymphocyte, which is less so infective, and platelets are low. So they present with classical history of bleeding, petechi, ecchymosis, blah 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 blah, excessive menstruation, bleeding per rectum, gum bleeding, long list. Anyway, so bleeding. So these are the basic things. So 20 to 50 years of female present with fatigue, recurrent infection, bleeding. Why? Because we have the reason. It's the pancytopenia. When all three low, it's pancytopenia. So what you see in the CBC is pancytopenia. So young female present with the pancytopenia, you suspected that why this lady has a pancytopenia. So you did a bone marrow examination of this patient, and in bone marrow examination, you see severely hypocellular marrow. Hypocellular marrow is a hallmark of aplastic anemia. What if it is hypercellular marrow? Then what is the diagnosis? When there is a hypercellular, 100% it is not aplastic anemia. It could be leukemia or it could be acute leukemia. It could be myeloproliferative disease. It could be hemolysis or severe sepsis, blah, blah. When there is a stress, these are the things where usually you get a hypercellular marrow. So hypocellular marrow, most commonest thing is aplastic anemia. Very rarely myelodysplastic syndrome you may present. Here I am also writing in hyper. I am also writing here in hypo. I'm absolutely conscious, well oriented with time, place, and person myself. But very rarely, MDS can present with the fibrosis and hypocellular marrow. But most of the time, it present with the hypercellular. But I have seen many patients, those who present with the hypo as well. So, aplastic anemia, MDS, right? Marrow infiltration with the malignancy, secondary infiltrates to the bone marrow, right? So, these are the few conditions where you can see the this hypocellular. Hypo means less. Now I want to show you what is a hypocellular. So this is hypocellular. This is a normal bone marrow. This is normal bone marrow. What you can see all round white is a fat globules, and surrounding this all pink and bluish cells. This absolutely a hematopoietic cells. RBC, WBC, platelet, this all. Here you see, you can't see anything, only just patch of the hematopoietic cell, just patch. Bone marrow is completely replaced with the fatty tissue or fatty cells or fat cells. That's it. There is no hematopoietic. Aplastic. A means absence. A means absence, and plasia means formation. So absence of formation of blood cell, right, which includes HB, WBC, and platelet from the stem cell. So absence of formation of blood cell is called aplastic. This is misnomer, but for many years and years it is anemia. So we are reading anemia, but by my sense, the name is aplastic pancytopenia. I teach to my student in resident while I'm in the round, I'll tell aplastic pancytopenia. Why? Because there is not only just anemia. There is low HB, there is low WBC, there is low platelet count. So it is a pancytopenia. But for many years it is going in the book aplastic anemia. So we are discussing as a aplastic anemia, but this is aplastic pancytopenia. Because I have not seen or very less patient in last 20 years, those who just present with anemia. 99% of the patients they present with pancytopenia or at least bicytopenia, not just anemia. So it is not aplastic anemia, it is aplastic cytopenia or pancytopenia. So now we'll exclude one by one, right? So now see, if the answer is CML, then what could be there? Dr. Kanika, if it is answer is CML, how the CML patient present? If I want to tell you in a one line of the CML, what I can tell you? Any idea, Kanika? If I want to tell you one liner for everything, one liner for only one line for all things, one line for CML, one line for myeloproliferative, one line for aplastic, one line for iron deficiency, one line for ALL. Anyone, any volunteer, any
Blast
volunteer.
crisis.
Sir,
Sorry, anyone, one by
Blast
one. So we
sir,
crisis.
can
in
discuss.
CML,
Yes,
may I
CML.
say?
Splenomegaly.
One, please, one, tell me one by one so I
So
can
premature
understand.
cell can will be
Sorry.
seen. Premature
Yes,
cells.
Splenomegaly.
Kanika. Yes, Kanika.
Splenomegaly.
CML, splenomegaly. Okay.
Yes, yeah. Okay.
So I will explain all five things. You listen it. If you have any questions, you get back to me. So chronic myeloid leukemia can occur at any age, even in a children, but usually in a middle age, usually present with the splenomegaly in more than 90% of the cases. If you do the bone marrow is hypercellular. Remember, hypercellular. Here they are saying hypocellular, so CML is gone. Plus, they will see Philadelphia chromosome, PH chromosome positive, that is translocation of 922, and drug of choice is a imatinib. Imatinib is a drug of choice. This is one liner. So if you remember this, you can answer 10 questions for CML because this is high yield point, right? Splenomegaly seen in 90. Here there is no splenomegaly. Here there is no hypercellular marrow. Here no Philadelphia chromosome. Here there is no translocation 9.9 and 22. So this is gone. Myeloproliferative disease. Myeloproliferative disease is a disease of old age. In myeloproliferative disease, there are four entities for your knowledge. Myeloproliferative disease. Don't mug up, rattafy mat karo. Don't rattafy. Myelo means bone marrow. Proliferative means proliferation of the hematopoietic cell or blood forming cell, and disease is disease. Myeloproliferate. So there is something excessive formation of blood cell. If it is in WBC, you can call CML. It is in platelet, you can call essential thrombocytosis. If it is in hemoglobin, you can polycythemia rubra vera, and if it is fibroblast proliferation, myelofibrosis. So if you open up the any book of myeloproliferative disease, this four will come, right? So this they all usually have hypercellular marrow. Usually they have hyper. Because why? Because WBC is forming more, platelet forming more, hemoglobin forming more, fibroblast. So they are usually hypercellular. So it is not again filling. Our keep an eye on hypocellular. Even if you keep this only one word in your mind, right? Then even you know. Here say no organomegaly. See, no organomegaly means no CML. Why? Because in CML there is organomegaly. 90% of the patient present with splenomegaly. Here no splenomegaly. So here these two things is enough to exclude. No organomegaly, bone marrow is a hypocellular, here hypercellular. So CML is gone. Simply, it's a logic, but this will come, this concept will come after treating hundreds of patients. So I treated, so don't get confused, right? But I'm trying to make your job easy, right? But you will learn a lot of things. So myeloproliferative, this all things, it's usually hypercellular. You never get, right? And in CML, you get splenomegaly. Here not. Essential, you get splenomegaly. Polycythemia also you get, and myelofibrosis, one of the cause of massive splenomegaly. If you go and read the chapter of massive splenomegaly, what are the causes of massive splenomegaly? Tropical malaria, Kala Azar, malignant lymphoma, myeloproliferative disease, any of these four, but myelofibrosis is notorious. Spleen starts from the left hypochondriac. I have seen in the right iliac fossa. I have seen myself, hundreds of patients, right iliac fossa. Complete whole abdomen, right, is covered with spleens. This is called massive splenomegaly, more than 20-25 centimeter long, right? So it is not there. Why? Because two reason: no organomegaly and no hypocellular marrow. Iron deficiency anemia, just anemia, low HB, but WBC and platelets are normal, absolutely normal in iron deficiency anemia. I'll take one time lecture of anemia to exclude all anemia. Iron, B12, folate, MDS, anemia of chronic disease, hemolytic, later on we'll see. But in iron deficiency anemia, you just see the low hemoglobin. What they are saying here, read the questions, because you did not read the question well. That is why your things is wrong. They are saying pancytopenia. So anemia is not pancytopenia. So iron deficiency is gone. They have not mentioned about anything iron. What is iron profile, right? They have not mentioned anything about the dietary habit that she is not taking. They have not mentioned anything about occult blood or stool blood or anything bleeding from anywhere major. So anemia will not develop without this. If you are eating well and if you are not losing any blood, you will not develop iron deficiency, right? And acute lymphoblastic leukemia, only one thing is enough. Acute lymphoblastic leukemia, there is a more than 20% of the blast cell in blood or bone marrow. They have not mentioned anything about the blast in bone marrow examination. They just mention hypocellular, and ALL is again hypercellular, 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 and they are asking the hypocellular marrow. So only one thing which fits to this is aplastic anemia. Now we'll see how this scenario fits completely exactly this aplastic anemia. That is the real learning, right? So I try my level best to exclude each and everything. Why this not, right? If you have any questions, ask me after 2 minutes. So I will discuss again, right? So what are the point favoring? So whenever this is again art, very important art of developing and solving the MCQ. So once you confirm the diagnosis that okay, this could be aplastic, retrospectively go to the MCQ and think what is, I mean, fitting to the aplastic. So first of all, 20 to 50, this is one point. Second point is female. Second point, right, recent illness because of pancytopenia. So this is suffering headache, bliss. This is part and parcel. So this is patchy and all, right? Third, there is no organomegaly. Never ever you see organomegaly in aplastic. So third point favoring. Usually MCV is high, more than 100. That is the fourth point. Fifth point is the pancytopenia, aplastic present with not just anemia, pancytopenia, and 100% bone marrow is hypocellular. So what else you need in these questions to solve this? If you know these six things, don't look at this. I never look at in my hematology patient when come to this. I'll see. I'll see my patient age. I see CBC and peripheral smear. And if I on this I can make the diagnosis query that this is aplastic. And bone marrow, if I do, then 100% it is done. Bone marrow, aplastic anemia, that's it. So that comes usually from the experience. Obviously, it's not come overnight, but still you need to think in that way, that how you can exclude the other diagnosis as well. Your job is not just to do the, I mean, doing the aplastic, but why not CML? Why not MPD? Why not iron deficiency? Why not acute lymphoblastic leukemia? Or why not it is anemia of chronic disease? Or why not it is a von Willebrand disease? Or why not it is a different disease? Or lymphoma? Why this is not a lymphoma? That is F option. So why this is not lymphoma? Simple. So if this is a lymphoma, say for example non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma, there is a lymphadenopathy. Here no lymphadenopathy. There is a hepatosplenomegaly, organomegaly, no hepatosplenomegaly. In lymphoma, usually don't see any pancytopenia. You just see rather increased lymphocytosis or lymphocytosis because it's a lymphoid malignancy. Na? Non-Hodgkin's lymphoma is a lymphoid or lymphoproliferative. So there is no pancytopenia. Bone marrow is usually hypercellular. Here they are saying hypocellular. So lymphoma is not there. That's it. Why I have clarity? Because I know how to treat it, how to diagnose it, how to investigate it. So you need for each and every questions, doctor, you need to acquire, right? The same style. So if you become an expert of excluding the things, then again you are expert, right? Because here now we did not mug up this question. We logically ruled out one from other. That's it. So this is what the thing is. So keep in mind, this is aplastic anemia, 100%. This is bone marrow I showed you, and bone marrow treatment. I'll just for your knowledge, I'm going quickly treatment because I need to know three things: diagnosis, investigation, treatment. Never ever miss. So treatment is bone marrow transplant. If you have HLA-MH, if you do not have bone marrow HLA-MH, then you can go for one treatment called ATG, anti-thymocyte globulin plus cyclosporin. Both are immunosuppressant drug which suppress the T lymphocyte and try to save the stem cell, right? Which is considered to be autoimmune disease. So ATG, cyclosporin or bone marrow transplant is the proven treatment across the globe, right? These are the two main treatment. So if somebody is affording first options, affording an HLA match, go for bone marrow transplant. It's a first option. That is why written here first. If no match, then you go for ATG plus cyclosporine. That's it. So this is what the things. Yes, Kanika, any questions? Anyone? Utpal, any question, doctor?
No, sir, it's clear. Thank you.
Wonderful. So there is no mug up. So we are clear. So when we understood the concept, we are clear. Anyone? Anyone has any questions? Because it's a very important questions, right? Very important. Fair enough. No questions means no query. I considered in that way. No question means no query. Next question: 34-year-old multigravida presents for prenatal care in the second trimester. 34 years, second trimester. She reports a history of substance abuse, but states that she has been clean for 6 months. 6 months she did not took anything. With her second pregnancy, she explained a preterm delivery, right, at 34-week gestation of a male neonate who died within the first day of life. At the delivery, the baby was swollen, skin lesion, and placenta was very large. She was treated with antibiotic, but she cannot remember what they were. So doesn't know the antibiotic name. On routine prenatal panel checkup with his current pregnancy, she found to have a positive VDRL. That is called Venereal Disease Research Lab. What is the next step in the management? Are you going to do FTAABS? Are you giving the intramuscular injection considering the disease? Are you going to do a lupus anticoagulant or oral penicillin you give to the patient, or you do RPR test known as a rapid plasma reagent? So again, the triad will come. Without triad, you cannot answer any questions. So anybody is interacting with me, I'm interested in three things. What is the
Sir, may I
diagnosis of this
know? Can I
patient?
say?
One, yes, sir.
Sir, basically this patient is previous in the history we can comment that this patient was diagnosed with the congenital syphilis. The baby died with the congenital syphilis. So
Okay.
here in this case we can go with when the VDRL test is positive, then
Hmm.
there it's better not to waste time to go with the FDA ABS for the confirmatory. We can go with the intramuscular penicillin injection as a prophylactic.
No, sir. We have to start go with the FTA-ABS because there will be false positive VDRL in many cases. So better to confirm with the confirmatory test and then go with the penicillin.
Yes, Dr. Utpal, you can answer of this lady, right? So this is a discussion that is extremely important. Now you want to
Yes,
comment
madam.
on the Dr. Preetis?
Yes,
because she told that
definitely. I would
VDRL
like
could
to
be
say,
false
yeah,
positive, right? So she
yes,
wants to
VDRL is
confirm.
false positive.
Yes,
Sir, here the history suggests that the patient is having congenital syphilis. The baby died with the congenital syphilis.
that is what we are
So
thinking. There is no
uh,
confirmed diagnosis. Even she doesn't remember
there
what
is,
happens last time, antibiotics, she doesn't remember. They mention she cannot remember what they were. She cannot remember. So this is just the history.
but
You need to
see,
believe
sir,
against.
here in the question with the history, it's saying that the baby was swollen with the skin lesion and the placenta was very, very large. Okay. So, and she was treated with antibiotics, but she cannot remember. But the thing is, here with the baby's lesion and the skin lesion of the baby, we could think that the baby was positive with the syphilis.
Fair enough. What is the guideline saying? What is the guideline? And this is practically what you and me are doing is a practical thing, but this is
Sir,
the answer for.
if I am the doctor and I am treating this lady, on my safer side, I will go with the FTA ABS. Then I will go
Great.
with the penicillin. But
Yes.
as the literature says, we can go with the penicillin
Yeah. So you just send me the
because of the
literature.
medical legal thing.
Fair enough. So you send the literature which mention that you don't need to confirm VDRL positivity, and you jump directly on the penicillin or the appropriate drug. Then just do let me know, because I reviewed my, when I come to the class, I do lots of hard work before presenting to you. Though this is my 1000 lecture, at least 500 is on YouTube. So this is 1000, non YouTube included. But still, I respect your word. So if you feel or if you find out any literature, we would be happy to know the new things. But as of now, what is in all current guideline book, whenever you found any positive VDRL test, you need to confirm it. It could be false positive, it could be anything else. So here, this is the literature, right? So here the answer is to confirm the test, VDRL positive and F, right? So once a next step after any positive screening test is to do the confirmatory test. So say for example, in a emergency room, we find that somebody is HIV positive in a rapid test, right? We must do the Western blot, confirm. Anything wrong, it's problem, right? So you
Understood.
confirm, right? So FTA ABS is the confirmatory test for the syphilis. Once syphilis is confirmed, then you give the penicillin. That's it, right? So I want to know, doctor.
Understood.
Yeah. So do you know what are the types of the syphilis? What are the types? No, not you, Doctor Utpal. You answered a lot. I mean, I want to go to another. Yes, Zainab. Any comment? How many types of how many types of syphilis? This is an exam question recently in DHA. How many types
Yes,
of things? You
we have
whatever
primary,
you speak, I will write. So
we
this
have
is questions,
primary,
type of syphilis. Yes. So I
primary,
will tell you the answer: primary, secondary, latent, and tertiary. Tell me, when you see this all time frame, what is the time frame of these three, all four? What is the treatment of four, and how do they present all four? Right? Just for your knowledge, I'll go quickly. This is the literature, right? So you must keep this chart in mind. So syphilis stage or types or stage mainly, right? So primary syphilis usually present within 1 month, from infection to 1 month. This is 1 to 2 months. 2 months to 1 year is a latent, and more than 1 year to 10 years is a tertiary. So after years and years of infection with the syphilis, after 5 years, you may present with the tertiary syphilis. What is the primary? They present with the chancre. What is the test? Dark field, most sensitive. Don't get confused. Primary dark field. Dark field is not confirmatory for secondary or tertiary. It is only confirmatory for primary. So this chart is extremely important. And RPR is the most important in primary, secondary, and tertiary. So RPR and FTA, fluorosoma triponopallidum antigen antibody. So RPR and FTA is the most important test, right? So if you don't know anything, you can do this test, right? But just for remember, for primary, if they ask what is the most sensitive test for primary syphilis, then only change answer is dark field. Otherwise, if you answer RB, RPR, FTA, you are right. And treatment is almost the same for all. primary is a single IM injection, single IM penicillin, only tertiary is a IV. Second question in exam, if somebody is allergic to penicillin, doxycycline, doxycycline, desensitization, because if the IV penicillin, you do the desensitization if they are allergic, but doxycycline will not work in a tertiary. So this is little change. So in primary, if they ask the diagnosis, most sensitivity change in the answer is that is a dark field is the investigation and treatment is a penicillin. If penicillin allergic, doxycycline will not work in a tertiary. That's it. So this is chart. I got it from the book only, right? But it is very handy and very important chart. So I posted here. Clear, Zainab? Any questions, Zainab?
No, sir.
Wonderful. Your homework is to read what is the presentation of primary, what is the presentation of secondary, what is the presentation. So here it is written. See here, Shankar, secondary they present with a rash, they present with alopecia, they present with condylomata lata and mucous or mucocutaneous patch. Tertiary is neurosyphilis, means brain is involved. TAPS dorsalis, general paresis, Argol Robertson pupil. Gumma and aortitis. So brain and heart is mainly the culprit. So any patients comes in ROPD with a stroke, our neurologist is always asked for the VDRL, and if positive, then they go for FTABS. That's it. So this is what the thing is. There are a lot of things to discuss, but I'm just going. So now we know the diagnosis of this patient, right? Likely VDRL is positive, FTABS. FTABS, what is the full form? Fluorescent treponemal, that is the name of the treponema pallidum, is the name of the organism which causes the syphilis. So it is a fluorescent. So they are seeing something in the fluorescent light. So fluorescent treponemal antibody absorption test. So this is a full form of FTABS. That's it. So you go. There are a lot of other things. If VDRL positive, FTABS positive, what is that? VDRL positive, FTA negative, what is that? Both negative, what? One positive, one negative, what? So I'll share this PowerPoint with you. Don't worry. So this is how you need to go, right? You don't need to mug up. So bottom line is that once the screening test is positive, you need to confirm it. That's it. Next questions, very easy. 32 years old Filipino woman, 15 weeks pregnant by dates. She present with painless vaginal bleeding with clear vesicle in vagina. Examination with severe nausea and vomiting. Her uterus extends up to the umbilicus, but no fetal heart tones can be heard. Her blood pressure is 162/98. A dipstick urine shows 2 plus proteinuria. Beta HCG is more than 100,000, means 1 lakh. Which of the following is most likely diagnosis? Chronic hypertension with superimposed
This is
preeclampsia,
molar pregnancy, sir.
eclampsia,
Molar
molar,
pregnancy, sir.
molar pregnancy, or preeclampsia. So take your time.
Molar
SCG
pregnancy.
is more than 1 lakh.
Yeah, take your time.
Mhm.
Yes, Pooja, would you like to comment, Dr. Pooja Suraj?
Yes, sir.
Yes. What do you think? What could be the diagnosis?
Molar pregnancy, sir.
So what are the point in aplastic? I mentioned 6 points here. Any points you can tell me that this goes in favor of molar pregnancy
Yes,
from the
sir.
scenario? No? Try to make a habit, Dr. Pooja. Do not read
Yes.
these options only. By this only you can make a diagnosis. By this only. So from now onwards, make the habit, right? Because
So,
when this possible, when you have complete clinical pictures clear, then without seeing the answer or options, you can say this is a molar pregnancy.
yes,
So
sir.
what are the points favoring the molar? Go.
So, painless bleeding with vesicles.
Vesicle. So vesicle is not seen in any condition. Hypertension, you cannot see vesicle. So chronic hypertension gone. This hypertension is gone. Eclampsia is a convulsion in pre-eclampsia is gone. And pre-eclampsia vesicle is not seen. So simple. Vesicle only can give you the diagnosis. These all are giving you to confuse you. 162. So you are going in front of for hypertension. If it is proteinuria, you are going for pre-eclampsia. This all are. And this pre-eclampsia, eclampsia, hypertension, you never ever see hundred thousands of beta HCG. Is that clear?
Yes, sir.
Any point want to add?
No, sir.
So what's the treatment? Puja. Just let the answer by puja
Her
only.
uterus
Puja.
extended to her umbilicus.
Yes, that is also there because you are it's a disproportionate. 15 weeks pregnant is not at the umbilicus. By my sense, it's a 24 weeks at umbilicus, and Ziphistatum is
Yeah.
36 weeks. This is what I remember, mota mota, right? So this is the things. Yes, Puja. So
And
if
no
this
fetal
patient
heart.
is Yeah, no
No
fetal heart.
fetal
That is
heartbeat.
extremely, yes, Pooja. So now this patient is diagnosed as a molar pregnancy. Next question: how you manage this patient? This is a question. Second MCQ: how you manage? What's the best appropriate management for this patient diagnosed as a molar pregnancy? Yes, Pooja.
Sir, dilatation and curettage.
Dilatation and curettage. Okay, fine. What else?
Methotrexate.
Methotrexate can
Methotrexate.
be given also.
Methotrexate. So how methotrexate will help in this patient? What methotrexate
Because this is
exactly?
आता नहीं लगता बारे
Sorry.
sir, molar pregnancy is precancerous and methotrexate is dihydrofolate reductase. It stops the growth of the cancer.
Okay.
Wait.
Great. So this is literature treatment is as follow baseline quantitative, not qualitative. Quantitative means you can measure, that is quantitative. Beta HCG titer, follow the serial beta HCG titer monthly until at least 6 consecutive value of 0. Chest X-ray to rule out metastasis, suction and dilatation and curettation. So D and C, dilatation and curettation with suction to evacuate the uterine content. Place patients on effective contraceptive, oral contraceptive pills to ensure no, right? To ensure no confusion between rising HCG titer from recurrent disease and normal pregnancy. So this is what the thing, and this is a classical picture. Can you know there is a one radiological name of these things?
Snowstorm appearance.
Snowstorm, excellent, wonderful. Snowstorm. So this is snowstorm appearance on the USG. So sometimes now what they are doing in DHA, they give just scenario and they give you the picture. Sonography looks like this, ultrasound looks like this. What appearance? Snowstorm. So you must know little basic pictures of sonography and X-ray. Last exam, there were few questions on X-ray and sonogram as well. So most of them they are there on our website. Go and see the picture MCQ on our website. Picture MCQ. So you get a lot of pictures. So that picture will help you to crack the exam questions. Next questions. 18 months old present with the fever for 1 week, a rash on his hands with discommission which developed today. That developed today. 18 months old boy. On examination is noted to have conjunctival infection, erythematous tongue, cracked lips, edema of the hand. He has palpable and painful nodes in the neck. What is the next step in the management? Anticoagulant, echocardiogram, IVIG and high dose aspirin, methylprednisolone, or just prednisolone is enough. Keep answer with you in your mind and brain. Don't disclose to anyone. Those who are giving me the answer, they are asking the management. But my first step, as usual, is a diagnosis. So anybody interacting with me, they needs to give me the first diagnosis or suspected
Kawasaki
diagnosis
disease.
or possible diagnosis
This
or
is sir
differential diagnosis.
scarlet fever.
Who told
Sir, I
scarlet
think
fever?
this is could be a scarlet fever.
Okay, so now again tell me the point in favor of scarlet fever. Tell me the point, which point
Sir,
favors the scarlet fever?
erythematous tongue, cracked lips, edema of the hands,
Erythematous tongue. What else? Second thing,
cracked lips,
Conjunctivitis.
cracked lips, conjunctivitis, edema of the hand. Why there is a edema of the hand? And why there is a palpable and painful lymph node? Do you see in scarlet fever palpable and painful lymph nodes in scarlet fever?
no, no, sir.
So so those who had not read the scarlet fever things, go and read how you diagnose, how you investigate, how you treat. What is the treatment of scarlet fever? Anyone?
Antibiotics.
Antibiotic. Which antibiotic? What is the commonest organism which do the scarlet fever?
Streptococcus
Streptococcus.
pyogenes.
Streptococcus. So go and read everyone. It is extremely high yield point, high yield topic, scarlet fever, scarlet fever. So now anyone wants to try these questions. If I'm saying this is not a scarlet fever, then what's the diagnosis?
Kawasaki disease.
Kawasaki disease, and this is the Kawasaki disease. So diagnosis is Kawasaki disease. What is the treatment of Kawasaki disease?
Hydro
Management.
say and IPIG.
Manjit, what
IV
is the
type.
treatment?
Sir, C.
Forget about this lady. She is giving a wrong answer. You give your answer.
Kawasaki.
Think of it and you give answer. Her answer is wrong. Don't influence with anybody's answer. You give your answer. Ishak, any question? Answer, Ishak. Maldiv. Ishak. Where is my friend Ishak? Pooja, what is the answer, Pooja? I will catch each and everybody
IV,
now. By name.
IVIG.
IVIG. What
Yes,
is the
sir.
diagnosis?
Kawasaki disease.
So what happens in Kawasaki disease? Tell me 2 lines about Kawasaki disease.
It is a vasculitis of medium vessel arteries.
Vasculitis of medium vessel. Excellent.
Yes.
So it is infective disease or inflammatory disease or autoimmune disease. Some bacteria causing Kawasaki disease or some autoimmune process called Kawasaki disease.
It's a inflammatory.
Sorry?
It's a inflammatory disease, sir.
Not
Multiple organ
infectious disease.
involvement.
Multiple organs. So it is not infection, right? It is not infection.
Yes.
Because of any bacteria, this does not develop. That is what I want to understand from you.
Yes, sir.
Autoimmune
Fair enough. So how, Pooja, this will help, right? Giving IV, IG and high dose aspirin. What is the importance of giving in Kawasaki disease? What it does? So this patient is a Kawasaki disease. Okay, fine. Diagnosis is correct. I'm convinced with your diagnosis. Kawasaki. So looks like a Japanese name. So Kawasaki. We have earlier bike called as Kawasaki bike in India. So this Kawasaki, same Kawasaki. So this what happens Kawasaki? If you give IVIG and aspirin in Kawasaki, how the patients get benefited? Pooja.
It prevents coronary artery aneurysm.
Excellent. Wonderful. You are
Oh,
pass.
next step is
Wonderful.
echo.
Sorry. Yeah, she is, hit the things because it prevents the things, right? So Kawasaki disease, you give IV, IG. IV means intravenous, IG means immunoglobulin. So intravenous immunoglobulin and high dose aspirin should be started immediately, not after waiting for some time. Immediately. Why you want to start immediately? To prevent coronary artery involvement. And if you start this both the things, what it does, it reduces the risk from 25%, right, to 5%. And echocardiogram or echo 2D echo should be performed for the baseline measure. And coronary artery abnormalities is the right usually occurs in a second and third week. So you don't want to miss this. Kawasaki is a bad disease, right? So Kawasaki is a mucocutaneous lymph node syndrome. Another name is the mucocutaneous lymph node syndrome is another name of Kawasaki. It is a medium vessel, as Dr. Pooja rightly said, medium vessel or medial muscular arteries, right? Coronary
Yes, sir.
artery disease, 20% of the cases, right? Key cause acquired heart disease in children, large coronary aneurysm can develop and death can develop because of aneurysmal rupture, right? And this is acute febrile illness, usually self-limiting, but you should give this. Fever, conjunctivitis is there, fever is there, rash, edema is there, edema in hand is also mentioned, lymph node is also mentioned, and strawberry tongue, strawberry pink tongue is also seen, right? Not just in scarlet, but in this also you can see. So this is the classical presentation of the Kawasaki disease. So don't get confused between scarlet fever and Kawasaki. And now your homework is more important. So how you differentiate between Kawasaki and scarlet fever? So go and read it. What differentiate from Kawasaki? So what is not this? Which of this thing is not seen in the scarlet fever? This is simpler question. So you go and read it. Little do exercise on Sunday. 7 questions. We are about to finish in 10-15 minutes. So just bear with me. 50 years old female noticed from neck swelling with history of palpitation, weight loss. What's your diagnosis? Very simple questions. Two-liner. We love two-liners, right? So 50 years female, form neck swelling, history of palpitation, weight loss. Your diagnosis. Toxic nodular goiter, simple goiter, thyroiditis, parathyroid adenoma. Chat box, please. Answer in chat box. Yes, Saima, if you can interact with me, how you explain this patient, Dr. Simon? Yes, please.
Yes, sir. Can you hear me?
Yes, yes, very well. Excellent. Go
So,
ahead.
as there is history of palpitation and weight loss, so with toxic nodular goiter, I think patient present with these symptoms. If we talk about simple goiter, then there are no palpitations or weight loss.
Fine. So, can you give me more clarity how you differentiate simple goiter versus toxic goiter? So, goiter is there.
So, on patient's presentation, as she or he presents, I mean, as there is history of palpitation and weight loss, I think in simple goiter, there is no such swelling or palpitation and weight loss.
Okay, so you mean to say if there is a weight loss is there, palpitation is there, right? Palpitation is there,
Yes.
it is toxic goiter,
So
which is
it's more
which is
likely
not
toxic
likely.
nodular
Yeah,
goiter.
absolutely. There is no weight loss, no palpitation. It looks like a simple, right? Right. So why
Yes.
these symptoms present in this patient? What is wrong in the
Um,
toxic goiter? Why this patient develop palpitation, neck swelling, weight loss? Why they
Sir, I
develop?
think due to excessive release of free T3 or T4, which leads to the
Okay.
appearance of symptoms.
So excessive thyroid hormone release, or you can say
Yes.
hyperthyroidism,
Yes.
right? Hyperthyroidism. Okay. So because of that,
Yes, sir.
right, they release the lot of thyroid hormone. So patient develop this, right? So now how to investigate? So if you want to
Yes, sir.
diagnose anybody as a toxic,
Hyperthyroidism.
right, toxic thyroid goiter, right, toxic thyroid nodule, if you want to diagnose anyone in this, I'm muting all. You can unmute and you can interact because somebody is not understanding. They are talking behind. Yes, Saima, you can unmute your mic alone, right? So what do you think? Right? How you diagnose? So you suspected this patient as a toxic nodular goiter, right? So is it a clinical diagnosis? Is it a laboratory diagnosis? Is it a radiology diagnosis? Or what diagnosis it is? Yes, Saima, you go ahead. You are going quite well. I'm happy. Your flow is nice. You can unmute. I muted all because some ladies was talking in between, so I muted all. You
Sorry,
can
sir.
unmute
Can you
now.
repeat? What did you ask?
I asked doctor that this goiter is a your answer is toxic nodular goiter, right?
Yes, sir.
So how did you suspect it? So is it a clinical diagnosis? Is it a radiological diagnosis? Is it a
Sir,
diagnosis
it's a
by doing some FNSE or biopsy? What? How you confirm?
sir, clinical and radiological.
Clinical and radiological. So clinical we have it,
Yes.
palpitation and weight loss. That is clinical. Now how you
Sir,
confirm
clinical and on
radiologically?
examination, there are multiple nodules. Like
Okay.
it's not, I mean, irregular in shape or size. There are multiple palpable nodules.
Okay. So second is a clinical in goiter. You can get multiple palpable nodules in the thyroid gland, right?
Yes.
Radiology. If you do the
Yes.
ultrasound of this neck region, do you see anything
Yes.
in this? What you see?
Uh,
Or
sir,
other way around?
again, there.
Yeah,
Sir,
yeah.
again,
Go
it
ahead.
will vary from normal shape and size. We will found some masses or I think irregularity
Fair
in
enough.
shape.
Fair enough. Fair enough. I'll
On
ask you the leading question, direct question, straight. What is the best diagnostic test for toxic nodular goiter? Best diagnostic test.
so there is a radiological test. I can't remember the name, but there
Fine.
is a
So that is your
scan.
homework. That is your homework. Sorry. Right? That is your
Yes.
homework. Because if this comes in your exam, you need to know now. What do you think? Did I ask you the very tough question?
No, not at all. But the thing is, I exactly can't
After
name
this
it.
lecture, your brain will work. After my lecture, your brain will start working on MCQ.
So
So far, we
won't
are
Okay,
we
mugging
go
up.
actually, this is the
thyroid
first
profile?
lecture I'm attending. Hope it will
Yes.
work.
Sorry, Saima.
Sir, this is my first lecture I am attending. Hope it will work next time.
Wonderful, wonderful. But so far, you are enjoying, isn't it?
Yes, yes.
Wonderful. I'm happy to listen this. You are enjoying. Yes, Kanika, you are giving some inputs. I can see you. You are
Yes.
trying to put your.
So won't we go along with first complete thyroid profile?
So thyroid function test basically, right? Thyroid profile means T3, T4, TSH, isn't it? That is thyroid
Yes, sir.
profile. Am I right or
Yes.
wrong?
Yes, sir.
Okay. So I'll write down here your list. Thyroid function test or thyroid profile, which includes basic T3, T4, TSH. Okay. What else? If again these questions, if I ask you, Dr. Kanika, what is the
Yes.
best diagnostic test for thyroid toxic nodular goiter? Best test, whatever in the world, which one is the best test? Oh, this is positive, sir. This is toxic nodular goiter. Don't worry.
So I think
FNAC,
ultrasound, see FNAC,
Thyroid scan followed by
FNAC,
FNAC.
Thyroid scan.
radioactive
Thyroid scan followed by FNAC. So what you get in FNAC? If you do the toxic nodule goiter FNAC, what will you see? You see some toxic cells in the microscope. So this is homework. We don't need to mug up anything. We don't need to mug. There are whole day lecture on thyroid. I'm just taking one MCQ, but I'm taking only the important, which is extremely important because we read 100 times toxic nodular goiter, but we don't know what is a toxic
to
nodular
rule out
goiter.
the malignancies, sir, the FNAC mainly is for.
Yeah, that is absolutely right. Any thyroid swelling, you want to rule out the malignancy, obviously, right? So it will, but what my question is here, not to rule out the malignancy. Here, my one question is, what is the best available test in this world which can confirm 100% or close to 100% that this is thyroid toxic thyroid nodule? So you go and read it.
so I
So
think we can also do radioactive iodine uptake.
Iodine craves. Yeah.
yes, so how does it help?
So
It
It
will
will do the
focally
uptake.
uptake the toxic
Focal
nodules, sir.
uptake would be there, right, in the toxic
yes,
nodular
sir.
goiter, which is not there in
Yes.
the simple thyroid nodule. I mean, simple goiter. Wonderful. So that is there. But still, I want you to read. Still, I want you to read, everyone. Right. So this is excellent picture. I got it from the internet. So I make it from internet only. So this is extremely important for sign and symptoms. So this is a thyroid gland. This is what I'm drawing is a thyroid gland. I love a picture. Huh? That is why I have lots of picture in my lecture because it brings clarity. And there are number four parathyroid. So two pair parathyroid. Recurrent laryngeal nerve is going from here. Okay, this is right. So this is the region. So here, see, this is a thyroid gland. I'm drawing this is thyroid gland. Number one is a thyroid gland. This is number one. Number two is a trachea. Number three is a esophagus. Number four, just behind the trachea and esophagus, there is a nerve called as a recurrent laryngeal nerve. So something goes wrong, thyroid enlargement, hoarseness of voice means recurrent laryngeal nerve is involved, right? Fourth number, right? Fifth number is a parathyroid. Yellow is a parathyroid. So behind thyroid, there is a parathyroid. So fifth number is parathyroid, right? This six number, seven, eight, all are muscle, right? 11 number, this is very important. Red is a carotid artery. Blue is a internal jugular vein and vagus nerve. So this is a vascular bundle. You need to know simple thing. What passes near when thyroid malignancy develop, it compress radial, recurrent laryngeal nerve. When it enlarge even more, it can compress this carotid artery. It can compress internal jugular vein. It can compress the vagus nerve. So lots of different symptoms you develop because of the thyroid enlargement. Simple, whether benign or malignant, because they compress. Now, when they compress the recurrent laryngeal nerve, you thyroid patient may present with hoarseness of voice. So it is explainable, right? Why? Because you now you know the anatomy. So excellent picture. I loved it. This, so I got it right. So this is the things you need to know. So this is goiter. Simple. What do you mean by goiter? First of all, you understand goiter, then simple and toxic. So goiter is just enlargement of thyroid. So any thyroid enlargement is known as a goiter. Then you divide it. Is a simple goiter or toxic goiter? That is the second question. But first, goiter means enlargement is there. You need to decide whether it is a simple enlargement or it is a toxic enlargement or toxic goiter. Goiter means simple enlargement of thyroid. So what is the toxic and simple goiter? Where did the basic questions comes in mind? So classification of goiter based on the thyroid hormone level includes toxic goiter. This goiter happens when your thyroid is enlarged and producing too much thyroid. So what happens in simple or toxic? Enlargement is there, but in simple there is no excessive hormone. In toxic, excessive hormone. That's it. So that is why how the classification comes, right? An optimal therapy for thyroid toxic nodular goiter remains controversial after differs slightly between the single domain nodule and multiple nodule. But patient who has an autonomous functioning nodule should be treated either with radioactive iodine is a treatment and surgery, or you completely do the total thyroidectomy or near total thyroidectomy or partial thyroidectomy, depends on the size, shape and symptoms of the patient. So this is how you do and how you differentiate from thyroiditis. So thyroiditis is present, it's a group of condition, is an inflammation of your thyroid gland, so it's not infection, inflammation. And Hashimoto's thyroiditis, this is thyroiditis. So Hashimoto's thyroiditis is the most common type of the things, and they usually present with the hypothyroidism, right? So this is what the thing is. So don't confuse between toxic nodular goiter. Usually they have hyperthyroidism, but Hashimoto's thyroiditis inflammation. The cells of the thyroid gland will not release the hormone well, so there is a hypothyroidism. The example is Hashimoto's thyroiditis. You treat symptomatically, surgery versus radioactive iodine. Yeah. So this is one or two questions I'll take. I'll take one this last PEP and then we'll I think hold for this today. We discussed a lot of interesting questions and we'll cover up in the next. So last concentrate, bear with me more 10 minutes. It would be again we are solving 10 question in 10 minutes in these questions only. So 33-year-old G1 P1 Gravida 1 Para 1 woman present for her gynec checkup or gynecologist for pap smear. Last DHA 2 days back, they asked 4 or 5 questions of cervical cancer, diagnosis, pap smear, leap, OSCOS, screening, and vaccine. Just for your knowledge, I'm telling you. So don't ignore. It has several years since last she saw a physician. She is not currently sexually active but takes oral contraceptive. A vaginal examination is normal, but pap smear shows moderate grade in cervical intraepithelial neoplasia. The patient undergoes colposcopies and biopsy, which confirms the diagnosis of what? Cervical intraepithelial neoplasia. What is the most appropriate management of this patient? Continue annual pap smear. So you tell this patient, don't worry, it is normal, nothing to worry. You come after 1 year, we'll repeat pap smear. That is A option. You directly do the LEAP, shortly called as a LEAP. So what is the full form of LEAP? So this is LEAP. First letter LEEP. That is shortly in the book it is called as a LEAP. So loop electrosurgical excision procedure. It's called LEAP. So you go directly LEAP for this patient. You do radiotherapy because it is a malignancy. Chemoradiation is a treatment. Then you do the colposcopy every 3-4 years. Every 3-4 months you do the colposcopy. Colpo means vagina, scopy means visualization. So there is a one scope like endoscope, right? Otoscope, ophthalmoscope. There is a scope to see the colon, colonoscopy every 3-4 months. And now it is a cancer, so you want to remove before it spreads to other parts of the body. So you do total abdominal hysterectomy. Put your answer in the chat box. I'll give you 10 seconds. We'll discuss. And exclude one by one, not just discuss. Exclude one by one.
It's B.
Yeah, you post. We'll discuss. I know you guys are hungry now. We have more than 25-30 doctors now, but only answer is 5. Yes, Dr. Ria, any comment? Dr. Ria, any comment? Yes, anyone?
I think it's B.
It's a B. Loop
Yeah.
electrosurgical. Yes. So what's your name, doctor?
Yeah, Dr. Shama from Jaipur.
Oh, sorry, because you are joined as a Samsung, so I didn't recognize. Sorry.
Yeah, I see.
Yes, Dr. Sama. So we'll discuss these questions with you and then we'll pack up. So first of all, tell me what is the diagnosis in this patient?
I think it's a
What?
neoplasia, cervical neoplasia.
So it is called shortly CIN, isn't it?
Yeah,
C for
yeah,
cervical, I for intraepithelial, and P and for neoplasia. So CIN, isn't it? How many types
yeah.
of CIN?
Uh, don't know
You
right
are,
now. Don't know.
sorry,
Don't know how many
you
types.
don't know.
I just,
So
yeah.
there are types of so so anyone wants to tell how many types of CIN, cervical intraepithelial neoplasia?
3.
Three type, one, two, and three. So out of these
Okay.
three, which is the this type? Which is the this one type? They are describing two type or three type in
Second,
this
I think so.
scenario. Huh?
I think it's second.
It's second. So how did you get to know this is second from the clinical scenario? Everything is in scenario. I will show you each
Yeah, I
and
think
everything in scenario only.
Grade,
Grade. So which grade?
moderate.
How? Moderate. So
yeah,
moderate is
moderate grade intraepithelial, yeah, cells.
okay. So what is a three? If it is a three, then what is in the scenario? What word in scenario? Severe. And one is a mild, moderate, and severe, isn't it? So this is a
Mhm.
moderate grade. So this is looks like a CIN2. Why I'm doing more in detail because the treatment is different in 1, 2, and 3. So what is the treatment now?
Mhm.
What is the treatment, Dr. Saima? Dr. Sama, sorry. What is the treatment?
Chemotherapy
If
and
you're no,
chemotherapy and radiotherapy. Yeah.
no, this is not a treatment for this is for cervical cancer,
Mm-hmm.
not for CIN. So if there is a cervical cancer, adenocarcinoma of cervix or squamous cell carcinoma of cervix, treatment of choice is chemo-RT, CT-RT, right? But this is not a full-fledged invasive. This is non-invasive. Biggest difference between cervical intraepithelial neoplasia and cervical cancer is a this is invasive, this is non-invasive. I will show you the details as well in next slide, but I'm trying to understand the concept, right? So CIN has a three type. How they differentiate? How did you get to know under microscope it is a mild, moderate, or severe? So this is the things I'll show you. Then your complete concept clarity. So this is a cervical pap smear picture. I got it right. This is normal. So if you can see this first this is absolutely normal cell, and this is the most important things which I want to draw it. This is this is basement membrane. This is basement membrane, right? So absolutely normal looking cells is a normal. This is normal. When this abnormal cell grow, right, because of infection, inflammation, or HPV, one third, one third of the thickness is involved, but the basement membrane is intact. It is not invasion, basement membrane, one third. It is mild or CIN1. If it is two, means two-third. Two-third of the thickness is involved. It is two, and complete thickness is involved. Three, but this basement membrane is not eroded. Here you can see no basement membrane. It goes beyond the basement membrane. And this is Dr. Sama called as a cancer. Full-fledged. So this is normal CIN1, CIN2, CIN3, and this is cancer. So here the treatment is CT plus RT. One repeat pap smear, one repeat pap smear after 6 to 12 months. 2 and 3, right? They are going badly. So leap is one treatment, and conization. So this is the treatment for 2 and 3. All right. So this is the treatment for 2 and 3. So let me get the picture. Probably I did not get the picture, but this is how we need to treat it. So this is what the thing is, right? So you need to know, all right? And it is, in another word, it is called as a mild. This is moderate. This is severe, and this is full-blown cancer. So if it is not developed cancer, you don't need to give aggressive treatment like surgery, chemo, and radiotherapy. You can do just the local lip electrosurgical procedure and conization, right? And here it is written management of cervical dysplasia. See, CIN1, repeat. This is CIN very early stage, very early stage. This is how they progress. And believe me, can anyone tell me from normal to cancer how many months or weeks or years will take from this to this? Here it is normal. Here, say for example, 2024 normal, 2025 cervical carcinoma in situ or CIN1, sorry, carcinoma cervical intraepithelial neoplasia, sorry, 2025. What do you think if you don't do anything? In what period of time it will develop to this stage? Anyone? Just general idea.
So 5 years, maybe within 5 years.
5 to
3
10
years.
years. No. It is not very fast, 5 to 10 years. Usually, right? So it is not overnight. Now this is a slow. Can anyone tell me which cancer is 100% preventable? Answer is cervical cancer, 100% preventable. There is a one vaccine called cervical cancer vaccine, and cervical cancer vaccine, it is a name is a Gardasil brand name, and Cervarix, Indian brand Cervarix, right?
Three
Can you
doses,
tell
sir.
me? Can you tell me, Doctor Kanika,
Yes.
what if the age is 11 years? How many dose? And if age is 45 years, how many dose?
Sir, actually, starting age is 9, and 9 to till 45 years of woman can take. And
Okay,
in
so I'm
9 years,
writing 9 to 45 years of age woman can take. So if some
yes,
female or girl come to you at 9 years of age, how many doses you
yes,
give? And at
2 doses, sir.
45, how many do? 2 doses you give,
Yes, sir.
right? At what interval you give?
I think, sir, interval of 6 months between 2 doses.
So one I
I'm not
given
very sure.
today, one I
6
had
months.
given today, second when I should give.
I think 6 months. I'm not very sure about the duration. I think
Fine.
6 months.
Go and read it. Your answer is correct, but still read it because it's a very important, hot favorite topic internationally now.
Yes,
Prevent
sir,
cancer by
definitely.
survival. And if the female comes at the 45 years of age, or
3 doses, sir.
right, 3 dose, what interval?
Again, same. I think 6 months between each and every doses.
So one today, one is after 6 months, another is after
Yes,
6 months. So this is
yes.
wrong. Go and read it. I know answer, but you read it so you understand. Second thing, in this vaccine, which strains are covered? Which strain of the HPV covered? If you give the vaccine, what are the strain covered in this vaccine? Can you tell me the name?
So 6, 11, 16,
11
and
and
18.
6, 6, 11, 16, and 18. Mug up. All these things mug up. I mug up. 4 strain. If you are covering 4 strain, it is called as a quadrivalent vaccine. Quadri means 4. Valent means covering 4 viruses. And nowadays there are more, right? 9 strains covered. Nanovalent is available. Nanovalent is available in market. 9 strains covered. So this is all high yield information. This is all exam related information for you to understand. So you must go and read each and everything about the pap smear. There are still more 100 things to discuss in pap smear. What is the starting age of pap smear? What is end age? If the pap smear showing abnormal result like Oscars, atypicals, comma, cell of uncertain significance, what comes? Right? If you club up HPV with pap smear, what frequency you can do it, right? Once the CIN3 develop, what will you do, right? And then once cancer develop, what will you do? What are the techniques and method to do the pap smear? what is the commonest pathology seen in cervical cancer? So like that, hundreds of questions I come across in my practice. So this is all asked in the exam, high yield. So thank you very much. I think I'm speaking from 1 hour and 41 minutes exclusively. So thank you, and thank you for your kind attention on the Sunday. So before I leave this meeting, I would like to have at least two or three volunteers very quickly, 1 minute give and share their experience of today's class, what they learned and what's the new for them in the class, and what new things they will get before class and after class. Kanika, I think you are the first. There are many doctors who join first time, and there are many
Yes, sir.
regular joining. So how was your experience? I mean, what before mindset before joining the class, and how was the experience? Did you learn something or not?
So learn a lot actually, because what we usually do when we do self study is like we just learn the correct answer and we just move on to the another question. In the class, we get to discuss each and every option in detail, and it gives us a lot of knowledge and a lot of clearance. So
Wonderful.
definitely, such kind of sessions are fruitful, and I think I'm looking forward for more, sir.
Wonderful. So you will get it. Don't miss my classes. Monday to Saturday, it's all subjective class. Means subject gynec dedicated. So in gynec class, only gynec will discuss. Pediatric, only pediatric. Surgery, but Sunday I'll try to mix up everything. So whole weeks, what you did, all brainstorming, I'll try to conclude your brainstorming once a week. 12 to 1:30 by default lecture. Fair enough. Anyone else, Saima? I think you also joined first time. So what's your experience?
Yes, sir, sure. Sir, in exam we get MCQs. So I what I realized is that whenever we even if we don't know the answer, so the method you have taught me, we can rule out the other options, and we are left with the one or two options. So it's easy for us to pick one. I mean, we are near to correct answer. And second
Exactly. If
thing
you are
is, in one MCQ you can get I think more than 5 or to 10 MCQs, like they get solved.
Yeah, so this is
So
what we need to learn, na? We are not here to just mug up the answer CIN 2, blah, blah, that's it. But they may ask you CIN 3, they may ask you CIN 1. I'm just trying to give you the
yes,
concept so you can understand complete things. That, okay, fine, this is the way how we need to do it, right? So that's the thing.
yes, sir.
So thank you very much again for your feedback, and just stay tuned. Yes, Dr. Ria,
Thanks, sir.
any comment?
Hello. Thank you, sir, for this wonderful section.
Great,
Hello.
wonderful. Any experience? We can hear you
Yeah,
well.
I am also for the first time attending this section. You just not just mug up the answers, but you discussed every aspect of it. I'm so thankful.
Great. So there must be a lot of learning to you today, isn't it? And few
Yeah, sure,
concept
sir.
clarities
Thank
as
you.
well.
Yeah, sure.
Wonderful. Wonderful. Wonderful.
Oh.
Yes, Dr. Utpal, any last comment? We'll pack up. Afreen Shah, I think Afreen is also you joined first time, right? Dr. Afreen Shah.
No,
Aishma
sir,
Neha is
second
also
time.
second
Second
time.
time.
So
Last Sunday I
how?
was there, and it's
Okay. So
wonderful, sir.
how is the
It's
experience today?
we are blessed to have you as a teacher, sir. Thank you so much. Happy Teachers' Day in advance, sir.
Thank you very much. Amazing answer. Very nice. Yes, Dr. Aishma Neha, any comment?
Really wonderful session, sir. I learned a lot and how to answer the MCQs by rule out the options. So it's really
Wonderful.
helpful. Thank you so much.
Wonderful. So implement this in your class. I mean your practice. When you are now doing alone the practice, right? Or rather, you can make a group of 2 to 3 people nearby your friends. We have hundreds of people. So those who are really genuinely interested in discussing the things, you can make one group of 3 people, 4 people. You can discuss amongst, right? The way we are discussing, come up with the queries. In our coaching, our coach are excellent. All super expert in their own field, right? So I'm more into the hemato-oncology as a hemato-oncologist, but we have excellent Dr. Aarti, Dr. Dipali, Dr. Shikha, all brilliant speaker. They are practicing for quite long, so they can make the main goal for me is to make the subject easy, not complicated, right? So if I make the things easy, you can better understand, right? Otherwise, aplastic anemia, MDS, leukemia is very toxic things, very complicated to understand, right? But if you understand the basic concept, it's easy for you to understand the things. Anyway, thank you very much all for joining. Stay tuned, keep in touch. I'll share this video as well very soon in the group. Thank you very much. See you.
Thank you,
Take
sir.
care. Bye bye. Take care.